முன்னாடி
ஓகே ஷூர். ஃபர்ஸ்ட் வின்ஸ்லி சார் இன்ட்ரோ듀ce பண்ணிட்டு அப்புறமா ஏபோ சார் அவங்க ஸ்டாக்குக்கு முன்னாடி இன்ட்ரோ듀ce பண்ணிடுங்க. Thank you.
ஓகே
Thank you.
ஓகே
மேடம் உஷா நந்தினி மேடம் வந்துட்டாங்களா சார்? ஸ்டார்ட் பண்ணிடலாமா சார்? இன்க்ரீஸ் சார் வந்து
Good afternoon, madam. நான் இங்க தான் இருக்கேன்.
Sir, you have come, sir?
Yes.
Oh, welcome, sir. Welcome. You are not in the video.
Oh, is it? No.
Oh.
No, I can see you.
I mean, my video is on.
Yeah, video is on.
Yeah, my video is also on.
Shall we start then, sir?
Yeah, I'm okay, madam. We can start.
Shall we start, sir? With permission, sir?
Yes, madam.
Okay, sir.
Sound correct.
Good evening, doctors. Welcome to our ECME, which is Series 3. And now we start with the IMA prayer by our Secretary, sir, Dr. Parameshwan, sir. He will lead us in IMA prayer.
Good evening to respected madam, treasurer, friends, seniors. மருத்துவரின் பிரார்த்தனை. எல்லாம் வல்ல இறைவா, உலகின் சிறந்த மருத்துவன் நீயே. உன்னை மண்டியிட்டு வணங்குகிறேன். உன்னிடமிருந்து நல்லதும் சிறந்ததும் என்னை அடைய பிரார்த்திக்கிறேன். எனது கரங்களுக்கு திறமையை தாரும். எனது மனதிற்கு தெளிவான பார்வையை தாரும். இதற்கு இரக்கத்தையும் கனிவையும் தாரும். எனக்கு அளிக்கப்பட்ட சிறப்பு தகுதியை தக்க வைக்கும் வண்ணம் வாடும் மக்கள் படும் பாட்டினை சிறிதளவாது போக்கிட ஒன்றுபட்ட எண்ணத்தையும் வலிமையும் தாரும். என் மனதிலிருந்து தகாத எண்ணங்களையும் உலகளவு ஆசைகளையும் அறவே ஒதுக்கி பணி செய்திட அருளுமாறு குழந்தை போன்று உன்னை சார்ந்து வேண்டுகிறேன். இந்திய பிரார்த்தனை. சேவை செய்யவே வாழ்வோம், அனைவரும் இன்புற்று வாழட்டும், ஒருவர் கூட வழியினாலும் வாடாமல் நாம் ஒவ்வொருவரும் பாடுபடுவோம். நாம் மகுடத்தை நாடவில்லை, சொர்க்கத்தை தேடவில்லை, பிறந்திட விரும்பவில்லை. சோகத்தில் கருதி வாழும் மக்களின் நோயை மட்டுமே போக்கிட விளைக்கும்.
Next we go to the flag salutation by Dr. Usha Nandini madam. Usha Nandini madam, you are there, ma'am? Hello? Usha Nandini madam, are you there? Hello? Can I do it, sir?
Yes, madam.
Okay. We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it, and realizing our responsibilities as accurate members of this national organization, we swear we will dedicate everything in our power to see it fly high in the comity of nations. Jai Hind, long live IMA. So now, I actually welcome address. This is Dr. Geeta Lysander. I extend my hearty welcome to our eminent speakers who are professors, Department of Pediatrics, CMC, Dr. Winsley Rose and Dr. EBOR Jacob. Both of them are very well known to us, and we have heard many of their lectures, very lively and very good lectures. And thank you, sir, Dr. Winsley Rose, sir, and Dr. EBOR Jacob, sir, for sparing your valuable time on a Sunday evening for us. And also we welcome you, sir, Dr. Winsley, sir, and welcome, sir, Dr. EBOR, sir. Also, we are looking forward to a lively session on clinical manifestations and management of SARS-CoV-2 infection in children and the critical care aspects of the same. I welcome each one of you doctors of IMA Ranipet for sparing time on a Sunday evening to attend this CME. Hope you will enjoy this academic session, and our speakers will be introduced to you by our Dr. Saravana Kumar sir after our secretary's address. Now, our secretary, Dr. A. Parmeshwan sir, will give his address. Sir,
Thank you,
Parmeshwan
madam.
sir.
Thank you. As a secretary report, respected President, madam, dear treasurer, seniors, friends, good evening once again. Conduct this month blood donation on 19/9 this month. Then this is the third ECME. We are organizing this meeting by ourselves. N95 mask and sanitizers on the way. Thank you very much, madam.
So, Dr. Saravana Kumar sir, you please introduce our speaker, Dr. Winsley Rose sir. Dr. Saravana Kumar sir. Dr. Saravana Kumar sir.
Madam, can you hear me, madam?
I can hear you.
Ma'am,
hear me?
madam, treasurer report,
It's
1
a
minute,
great
madam.
pleasure
Okay,
and
okay, sir.
After the
honor
introduction.
Okay, sir.
It's a great pleasure and honor to introduce ma'am.
Sir, 1 minute, sir. The treasurer, sir, has a small report, sir, before that. Sorry, sir. Sorry to interview.
No problem.
Treasurer, sir, Dr. Srinivasan, sir.
Continue பண்ணட்டுமா sir?
Dr. Srinivasan, sir. Treasurer,
Good evening
sir.
to all. It's a great pleasure and honor to introduce the
Mr. Prem, there are a lot of disturbances inside. Hello, Mr. Prem.
Madam, you have to unmute yourself. Now I muted everyone.
Yes.
இப்ப டிஸ்டர்பன்ஸ் இருக்காது, பேசுங்க.
Okay. Thank you.
shall I start?
Yes, sir. Yes, sir. Dr. Saravana
Good
Kumar,
evening
sir,
to all.
please.
It's a great pleasure and honor to introduce the eminent speakers of the day. The first speaker of the day will be our Professor Winsley. Yes, ma'am. Started, ma'am. To introduce the eminent speakers of the day to all our IMA members. The first speaker of the day will be our Professor Winsley Rose, Professor of Pediatrics, CMC Vellore. Sir has completed his MBBS and MD from CMC Vellore in the year 2003. After completing his MD, Sir joined the Department of Pediatrics, CMC Vellore, and then in the year 2010, Sir did his fellowship in pediatric infectious diseases at Hospital for Sick Children, Toronto, Canada. After finishing his fellowship, Sir returned back to CMC Vellore and joined the Department of Pediatrics, and now currently working as a Professor of Pediatrics in CMC Vellore. Regarding his achievements, Sir has got a Best Thesis Research Award in year 2003 from the Indian Journal of Pediatrics for his paper on intermittent clobazam therapy in febrile convulsions in children. Also in the same year, Sir also got Dr. V. Balagopala Raju Award during the annual conference of IAP Tamil Nadu, and also Sir has been given awarded Captain Jai Singh Memorial and Mr. Dr. Stablet and Monogran Prize for best outgoing student during his MD. As also, Sir has about around 36 papers published in various journals and various conferences to his credit. And sir is also most interested in research work, and his field of interest is pediatric infectious diseases. And currently, he is the principal investigator in ICMR supported research on burden of asymptomatic dengue infections in hyperendemic urban setting. And he is also currently a co-investigator in Bill and Melinda Gates Foundation supported research on national surveillance system for entry fever in India. Professor Winsley Rose for sparing his time on the Sunday evening for our IMA members. And now I hand over the podium to sir. Thank you.
Thank you, sir, for the nice introduction of our eminent professor from CMC, Dr. Winsley Rose. Sir, Winsley Rose, sir, please start your talk, sir.
Yes, ma'am. Thank you for the introduction. Let me see. Actually, there's a lot of disturbance. Just tell me if I'm trying to share my screen, and I need to be enabled to actually share my screen. Can
sure, sir.
somebody enable me to,
Mr. Prem, please enable him to share the screen, no?
Yes, madam, he is on the screen.
Okay, sure.
You are on the main screen, sir.
So it still says I think you'll have to make me a co-host. Then maybe I'll be able to share my screen.
Yeah, you have to click on Dr. Winsley's name, and then you have to make him as a co-host.
Can you do that, Mr. Prem?
Yes, madam, I can try.
Sure.
There is one option, make host.
Yes.
Yes.
Yes, sir.
Thank you. I think now I'll be able to share my screen. Yeah. Is that visible?
Yeah.
Yes,
Yes, sir. You're visible.
Okay.
COVID-19 in children.
Correct. Yes. So anyway, thank you for this invitation. So what I'm going to do today is to, try and give you a sort of an update on what COVID-19 is like in children. It's a new disease. There is information emerging almost every day. I think over the past 3-4 months, the number of publications that have come are are enormous, and there is a lot of information overload. And I'm sure all of you also recognize that, there are many number of WhatsApp forwards. There are many people discussing COVID at all sorts of fora. So which also means there is also wrong information which is also spread. So what I'm going to try and do is actually I'm going to make it simple to try and see what we know so far about COVID-19, especially in children. I'm not going to touch upon too much about the management aspects, which Dr. DR.EBOR will in his talk also touch upon, because COVID-19, even in adults, a bulk of them actually go with very mild illness and get away with it. It's even more so more so in children. Most children really don't have a very great illness. So we really don't do much with these children who are affected with COVID-19. In CMC itself, I think so far we've had about 300 odd children who have been admitted with us with COVID, and really we've had very few children who've been very sick. And Dr. DR.EBOR will actually touch upon those issues where these children come in sick with COVID-19. So what I'm going to do today, so this is going to be my outline. Is my slide changing?
Yes, sir. Changing.
Okay, so this is going to be my outline. So I'll just give you some little bit about the basics of COVID-19, a little bbit about its transmission, some clinical features, especially in children, and this particular entity called NMISC or PIMS-TS. which is something which is unique to children, which is a feature which happens in children with COVID-19, and a little bit about what the treatment protocol that we follow in CMC is, and a little bit about what preventive measures we can take. We can have discussion at the end. A lot of you may not be treating children with COVID-19, but you might have questions with regards to how to sort of, manage children who are coming to OPD, and what should your worries be, and those kind of things. I'm happy to take those kind of questions at the end after maybe after this talk, or even after Dr. EBOR's talk. So basics. So the COVID-19 is caused by SARS-CoV-2 virus. So COVID-19 stands for coronavirus disease 19, because it was identified in the year 2019 in December. And the virus itself is called severe acute respiratory syndrome coronavirus 2, because there was already a SARS virus which was identified in 2002. Now, coronaviruses are a very large group of viruses. There are many viruses, many coronaviruses, which actually cause common diseases among humans and among many animals. Now, there are 4 types of coronaviruses which are recognized, and the 4 groups are alpha coronaviruses, beta, gamma, and delta coronaviruses. Now, of these, it is within the beta coronavirus that SARS-CoV-2 belongs. Now, if you look at it very carefully, I don't know whether my pointer is visible. Is it visible? Is my pointer visible?
Yes, sir. Visible, sir.
Visible? Okay. So you can make out that in subgroup B, there is SARS coronavirus. And it is also very close to a bad coronavirus. So a lot of them are actually bad coronaviruses, and the SARS-CoV is actually in the subgroup B of the beta coronavirus. Now, out of these, only there are, if you look at all these viruses, human coronavirus NL63, 229E, then HKU3. So these are some of the viruses which actually cause human disease. Most of them are actually animal, only cause disease among animals. So normally where do these coronaviruses come from? So this is just to give you an idea about the coronaviruses which actually cause disease among humans. Now, of the coronaviruses which cause disease among humans, there are 3 coronaviruses which cause severe disease, out of which it is the SARS-CoV, that is the SARS coronavirus, which caused the SARS in 2002, and the MERS-CoV, which is the Middle Eastern Respiratory Syndrome coronavirus, which actually caused disease in 2012, and this was in Saudi Arabia. So primarily, these coronaviruses actually hang around in bats or rodents. And from the bats, they get on to some sort of mammals. And from these mammals, they switch over to humans. Now, if you look at SARS coronavirus, the original SARS virus in 2002, it was, it's the civet cat, which actually, from the bat, it jumped to the civet cats. And from the civet cats, it came into the humans. And this SARS-CoV was through the pigs. And MERS coronavirus, which was identified in 2012, is through camels. Now here we have the SARS coronavirus. We still don't know what is the animal that it came through, but we think it has actually come from the bats, because it's got about 99% similarity to a particular bat coronavirus. So because of this, we think it's come from the bat, but we don't know how it jumped from the bat into the human. There must have been some sort of an intermediate mammal. People think it's the pangolin. I think there's a lot of debate as to what is the animal which caused, where it came from, where the bat, from the bat, which animal it went into, and then it came to the humans. Now, So these are the 4 coronaviruses which cause human disease. And I don't know whether how many of you have used multiple respiratory virus panel. Have any of you used a multiple respiratory virus panel? It's a PCR test which we used to do, which is done even now to find out what respiratory virus causes a particular infection. If you use that panel, you will find that there will be coronaviruses like these OC43, HKU1, 229E, NL63. All these are part of the original multiple respiratory virus panel. I should tell you a story because there is somebody in initially when the SARS came, before we had any patients in CMC, there was an instance where somebody found that it said the test said coronavirus positive, but they didn't realize that coronavirus was actually OC43. And somebody publicized it. It came in the paper saying there is a SARS case. There is a COVID case in CMC VELLORE. But actually, what they didn't realize was that it was not any coronavirus is not a SARS-CoV-2 coronavirus. This was actually a OC43. These are all very common coronaviruses which cause like a common cold, that kind of virus. What we are really worried about are these 3 viruses. That is the MERS coronavirus, SARS-CoV, which is the original, the first SARS coronavirus, which was in 2002, 2003, and then the SARS-CoV-2, which is what is the current coronavirus, which is circulating. Now, mind you, this MERS coronavirus, which is in Saudi Arabia, that also causes outbreaks every now and then. And that has a much higher mortality rate than the SARS-CoV-2. But the MERS coronavirus, it doesn't cause such, it's not so infective. So it's been controlled. So it doesn't cause so many people to become sick, unlike the SARS-CoV-2, which right now, it's all over the globe, and it's caused the disease in, I think, about 60 lakh people or So that's a little bit about these coronaviruses itself. It's important to recognize this because not all coronaviruses cause severe disease, but there are coronaviruses which can cause severe disease, of which what we are dealing with right now is the SARS-CoV-2 coronavirus, which is a beta coronavirus. Now, coronaviruses, if you can just sort of think about it from its name itself, it's like a crown. The round, it's a spherical virus, which has 3 structural proteins, and it's got a lipid bilayer. It's a lipid bilayer onto which these structural proteins are actually attached. And the 3 structural proteins are, one is the N protein or the membrane protein. Then you have the E envelope protein or the E protein. And you also have the spike protein. Now, this is the spike. So why these proteins, why I'm telling you about all these is because one, the spike protein is the one which actually attaches to the human cell and gets into the human cell. So this lipid bilayer, if you can imagine, this lipid bilayer is the one which actually gives the virus the integrity of the virus. So, and since it is lipid, it's like fat. It's like, you can sort of imagine washing oil with soap, no? If you wash oil with soap, the oil gets washed away. So if you wash this virus with soap, if this comes into contact with soap, this lipid bilayer actually can disintegrate and kill the virus. That is why soap and water is so effective against this particular virus, because it actually disintegrates this lipid bilayer. Now I told you about the proteins which are there. Now, next, I'll just tell you a little bit about the genome, which actually codes for all these proteins. I want your attention onto 3 particular areas in the genome. One is this RNA-dependent RNA polymerase genome. This is a RNA virus, which means it gets into the cell. It doesn't have to get itself into the nucleus of the host cell to be attached to the DNA. because it's just an RNA virus. So it uses this enzyme called RNA-dependent RNA polymerase, and then makes more copies of itself inside the host cell, and then comes out as a new virus. Why I'm telling you about this RNA-dependent RNA polymerase is because this code, I mean the genetic part which codes for this enzyme, is what is used in the PCR tests. So the PCR tests use two things. One is the E antigen. The E antigen is actually common for all coronaviruses. Sometimes you might find somebody say that they were tested positive, but then the next day they said the test was negative, because the test itself is done in two stages. The first stage, they look for this E antigen. So which means this, when you look for this E antigen is common for all coronaviruses. So first stage is to find out if it's a coronavirus. And the next stage is to find out whether that coronavirus is a beta coronavirus, which is SARS-CoV-2. And that is done by looking at this RNA-dependent RNA polymerase region, RDRP region. In some tests, the ICMR, some tests also use this ORF1b region. So first they find out whether it's a coronavirus, and then find out whether this coronavirus is a is a SARS-CoV virus or not. So this is pretty much a diagrammatic representation of what the virus does. So I told you about the spike protein. So the spike protein gets attached to the host cell. Now the host cell, the receptor of the host cell is the angiotensin converting enzyme 2. So ACE2 is the primary, it's the receptor on which the spike protein attaches. Now there is a co-receptor, which is basically a serine protease, which primes this S protein to attach to the ACE2. Now you can sort of imagine, like, you know, when you think of medicines which are being developed, you could develop a medicine for this serine protease, or even something to block this, and all of this could actually block the entry of the virus. So this virus gets into the host cell by endocytosis, and then it's only an RNA virus. So the RNA comes out and it releases, and with the help of this RNA-dependent RNA polymerase, it makes many copies of the same thing, and then it gets packaged again, and the virus is released. So this is how the virus attacks the human cell. Now, any cell which actually has a lot of this ACE2, angiotensin converting enzyme 2 receptor, is susceptible to this entry by the virus. And the respiratory epithelium has a lot of these receptors. So that's why it sort of is very effective in affecting the respiratory epithelium. The virus itself is about 50 to 200 nanometers in size. Okay, now that is a little bit about the virus itself. I mean, I'm just telling you a little bit about the basics, so that when you look at a test or when you look at a drug, you will sort of, you can think where this, what it means when somebody says, okay, the RT-PCR was positive, or the initial RT-PCR was negative, positive, but then they said negative. So all this is because of this, the dynamics that I just spoke to you about. Now, a little bit about the transmission. Now, if this was initially when in Wuhan, when it happened, when Taiwan said there is something which is happening in China, so people thought this was a virus which transferred itself from animal to human, and they thought it could not transmit from human to human. That is why China also sort of played it low, thinking it's a small outbreak from animal to a human, and only from a human to human, when that transmission happens, it becomes a pandemic. If it's only from animal to human, if you take away humans from that animal, then you can pretty much stop that. It can become like you can stop that epidemic. But unfortunately, this virus is very effective, not only in transferring from animal to human, it is also very effective in transferring from human to human. So now humans have become carriers as well as hosts for this particular virus. Now, how does it spread? So it's important to recognize there are three main modes in which it can spread, of which by and large, the most important mode of spread is this droplet spread. Now, I think people are very confused about how all it spreads, but this is by far the most common mode of spread. That means the droplet means that is, well, let's say if I've got SARS, like COVID, and if I am coughing or sneezing or I'm talking very loudly or singing or whatever, like if you stay very close to me, like within 1 or 2 meters, I generate droplets, and these droplets directly come onto you and you will get the infection. That is the most common mode by which it spreads. Now, these droplets are more than 5 microns in size, and which also mean if it's a more than 5 micron droplet, it will settle within a distance of about 6 feet. WHO says 3 feet, CDC says 6 feet. So I think somewhere between 3 and 6 feet, the droplet settles. So if you can sort of imagine, if you just maintain distance itself, it is a big deal. The next common mode of transmission is aerosols. That is, the size of the diameter of the droplet is less than 5 microns. Now, if a droplet is less than 5 microns, it can actually go in the air. So even if I'm sitting in one place, I can transmit to somebody who's sitting at the edge of the room if the size of the aerosol is less than 5 microns. This is also a possible modes of transmission. Now, if let's say you're sitting in a very closed room, and if you generate a lot of aerosols, it can easily transmit from one person sitting here to the somebody sitting far away. Now, if you sit in a very open room, or if you sit in then the chance of getting transmitting the virus also decreases considerably. So you can imagine if you're traveling an AC bus or an AC car versus an open bus or an open car, the chance of transmission is that much lesser. There was a very nice graph which was put out by the Hindu, where they've said, if you actually sit in open air spaces, even if crowds get together, the chance of transmission is very low. Whereas compared to sitting within a marriage hall and having a wedding ceremony within a marriage hall. So then the risk of transmission is very, very high. The next mode of transmission is by fomites. That is, you cough, or you, let's say I have secretions on my hands and I touch somewhere and that particle is sitting there, and then you touch that particular particle, and then you take it into your, and then if you take it into your nasopharynx, and then you get it. Now this, earlier people used to think this is very important, but now less and less people think it is important. In fact, CDC says fomite transmission is very unlikely, but the hand washing is basically to prevent this fomite transmission. WHO still recommends that fomite transmission is important and recommends hand washing very strictly. Even CDC recommends hand washing, but by and large, the most important mode of transmission is droplet. Next may be aerosols, and next may be fomites. Somebody raised their hand, so I don't know who it was. Can you, you can ask your question. Is there anybody among the audience who wanted to ask a question? Okay, if not, we'll leave the questions to the end. So who can spread, we know how SARS-CoV-2 spreads and who can spread it. So anybody who has got SARS-CoV-2 and is asymptomatic or symptomatic can spread the disease. So just because you're asymptomatic doesn't mean that you can't spread. So in fact, people think the asymptomatic ones are the ones who actually to account for the bulk of the spread that happens. Because they're asymptomatic, they are walking around, going around wherever, and they don't recognize that they are sick. People also don't recognize they are sick. So they don't take precautions. So that the asymptomatics actually contribute a lot to the spread of the disease. Of course, symptomatics can also spread. So when can you start spreading from? So symptomatics don't start spreading only from the date of their onset of symptoms. They actually start spreading 1 to 3 days before the onset of symptoms. That is very important to realize. The pre-symptomatic spread is actually much more than the symptomatic spread, because the day 1 to 3 days before they become sick is when most spread happens. And how long can they spread? For asymptomatic people, we really don't know how long they spread, because they are asymptomatic. We really don't know like when they got the disease, when they become free of the disease. That is not very clear. But what we know is, if somebody has mild to moderate disease, they will spread for about 10 days from their onset of symptoms. So they start spreading 1 to 3 days before onset of symptoms, and they go on spreading till 10 days after onset of symptoms. If somebody has got severe disease, or if they are immunocompromised, like let's say somebody who's on chemotherapy or immunosuppression for whatever reason, they can continue spreading for up to 20 days. So by and large, by 10 days, after 10 days, most people do not spread the virus. So if you look at quarantine norms, that's why people say up to 14-day quarantine and some say 24-day quarantine. So all that is because people stop spreading after day 10. If they have severe disease or if they're immunocompromised, they stop spreading after day 20. Now, I told you about when a person is infectious. Now, I want you to also recognize what an incubation period is and what a latent period is. Now, incubation period is, let's say I get the virus inside me today and I start symptoms 3 days later. So that is the incubation period. That is from the time I get the infection to the time I start clinical symptoms. So that is incubation period. That for COVID-19 is anywhere between 2 and 14 days. Whereas latent period, that is the time when you got the infection to the time when you start spreading the infection. I told you that pre-symptomatic itself you start spreading, which means the incubation period is actually a lot longer than the latent period. So there is a subclinical period before you develop symptoms that when you actually spread. And that subclinical infectious period is anywhere between 1 to 3 days. And what is the infectious period? It is from onset of symptoms to 10 days after the onset of symptoms. Now, usual incubation period is about 5 to 6 days. So from the time you get exposed to someone, you can transmit after about 5 or 6 days. You can develop symptoms after 5 or 6 days. But incubation period can be as long as 14 days. So just because you were in contact with someone with coronavirus, like COVID today, you can't be easy till it's about 14 days, because you can still develop symptoms even after 14 days from that time of contact. So anyway, so since after this, the talk is primarily going to be pediatric. If you're wondering whether any pediatric talk is going to come at all, after this it's going to be pediatric. So how do children get COVID-19? So most often children get it from the adults, because where do children get together? Mostly in schools, and schools are closed. So right now, children mostly get it from adults, and not because children can't transmit. They only get it from adults because they don't come into contact with other children, and they are more often in contact with adults. And they can also get it from other children. There is also, small babies can actually have in utero transplacental transmission. So in the 3rd trimester, the virus can actually get into the placenta, cross the placental barrier, and get into the fetus and cause disease in the fetus. And when the baby is born, the baby can be born with COVID disease. So transplacental transmission also can occur, but it's all uncommon, but it can occur. If a newborn baby develops COVID disease, it is more because the mother has got COVID disease and the mother has spread it to the baby through droplets, rather than transplacental transmission. Transplacental transmission occurs, but by and large, the most common mode of transmission is by droplet. Can it get transmitted by breast milk? You can actually get the viral particles in breast milk, but we don't really know whether breast milk transmits the virus. People think it is unlikely to be a source of transmission. So if a baby is in contact with the mother and gets the disease, it is more likely because of the close contact and droplets rather than via breast milk or by transplacental transmission, though both are possible. So in a newborn, newborns actually, it's not recommended that you separate the newborn from the mother, because even if the newborn develops the disease, it's actually a mild disease, and you really don't need to separate the baby from the mother or stop breastfeeding. I mean, you can continue breastfeeding. So that is what all guidelines are. Now, how well can children transmit COVID? Like, just because children have very mild disease, it doesn't mean they are not part of your transmission cycle. They can transmit COVID. They can actually transmit it as well as the adults. Whether symptomatic or asymptomatic, children transmit as well as adults. And people have looked at viral loads in the age group between less than 20 and above 20. And the viral loads in both these age groups are similar. And for the same kind of disease, like mild to moderate disease, viral load in less than 5 years is actually higher than that in over 5 years of age. So children definitely do form a part of the transmission chain. Now, a little bit about the clinical features of COVID-19 in children. Now, like I told you, COVID-19 in children is by and large, a mild disease. Like I told you, we've had over 300 children who've come with COVID. There are very few people who are very sick. And Dr. EBOR will touch upon those people who really became sick with COVID. So when I did my time in the COVID wards, we had a lot of children admitted with COVID. By and large, they were all asymptomatic. And even children who had cancer, who had surgeries, and who were COVID positive, they really didn't become sick because of COVID. So by and large, COVID in children is a very mild disease, but there are certain things that you need to keep your eye out for. So this is a summary of of the clinical features in children from about 8,000 children. This is primarily from the United States, and the adult data is also primarily from the United States, and this data is from over 360,000 adults. So if you look, for all those who are, 1/5 of the children were asymptomatic. I think if we look at our own data, I think maybe half of them would have been asymptomatic, and the other half would have had only mild symptoms, and only a smaller percentage would have had actually significant symptoms. So of those who are symptomatic, it's sort of divided into 0 to 9 years, 10 to 19 years, and adults. Fever was present in less than half, even in adults. And cough was more common in adults than in children. Breathing difficulty, that is actually only 7% had breathing difficulty compared to almost 30% in adults. So as the age increases, breathing difficulty also increases. In our own situation, even the very sick ones who came with the COVID and went into ICU, only 4 of them actually developed, out of some 30 odd patients, only 4 of them actually had any significant breathing difficulty. They all had they were all in ICU because of other reasons like shock rather than breathing difficulty. Headache, less than 9 years, very little. But in the older age group, in older adolescents and adults, headache is a common symptom. Nausea, vomiting happens in about 10% all across the board. Sore throat, less common in small children, but more common in older children and adults. Rhinorrhea. I mean, normally when you think of coronavirus disease, it's actually like a common cold. Whereas with SARS-CoV, it's not like common cold. So rhinorrhea is actually less likely. I mean, only 7-8% actually have rhinorrhea, but they can have that also. Myalgia, again, less reported among smaller children, more among older children and adults. Abdominal pain can happen. Diarrhea seems to be one of those symptoms which comes fairly often. About 15 to 20% of people have diarrhea. And the loss of smell and taste, which is like a very, I think people always associate COVID with loss of smell and taste. I think it's a very important sign. If somebody's got loss of smell and taste, I think it's very likely to be COVID. But in small children, it's very, very uncommon. Whereas it happens in about adolescents, it's there. I mean, I remember speaking to one child with COVID. She said, I mean, she was fine till one day she felt that she couldn't smell, and then I mean, by the time parents were positive, and then we checked this child, this one also positive. But so it happens, but it's not so common. It happens in about 10% of the children. In smaller babies, they can have different kinds of presentation. They can just present with feeding difficulty or just as a fever without focus. Respiratory symptoms are minimal in smaller babies, and they can also sometimes present like a bronchiolitis. So really, if you ask me, really you can't say who's got COVID or don't have COVID. Like we've picked up COVID out of, I mean, asymptomatics, all sorts of symptomatics. Children coming with febrile seizures, you do COVID test, it's positive. Children coming with bronchiolitis, you do COVID test, it's positive. You really can't make sense out of the clinical features and say, okay, this person will have COVID or not have COVID. Maybe that feature is probably that loss of smell. If somebody's got loss of smell and taste, I think COVID goes a little bit higher. But otherwise, we really can't make out who's got COVID or not have COVID. There are some rashes which have been described with COVID. Probably the common ones which we've seen are this mobiliform rash. This mobiliform rash which happens. Livido letricularis, that is this marbled appearance, that is also being described. Then in the Western literature, there is a lot being talked about the COVID toes. That is, it is like a frostbite. No, so that is being talked about a lot in Western literature. I have not seen one. I don't know, maybe some of the children who have come to ICU, Dr.EBOR can say whether they've seen or not. Urticaria has also been described with COVID. But by and large, what we may see is the mobiliform rash. So then moving on, this is probably the one thing which is actually very different about COVID-19 in children. That is this syndrome called the multi-system inflammatory syndrome in children. The American terminology is the MISC, that is a multi-system inflammatory syndrome in children. In the English, the UK people call it the PIMS-TS, that is Pediatric Inflammatory Multisystem Syndrome, temporarily associated with SARS-CoV-2. So that is the PIMS-TS. Both of them actually refer to the same syndrome, and it is something which is only described in children and not in adults. I think it's important to recognize this. So this is slightly different. Everybody who presents with this have fever, and it's usually about 4 to 6 days of fever. A lot of them have GI symptoms, including abdominal pain, vomiting, and diarrhea. A lot of them have a rash. It's almost like Kawasaki-like disease. You must have heard about Kawasaki-like disease in COVID. So that's what this is. A lot of them have conjunctivitis. They have mucous membrane involvement. They can have headache, lethargy, or confusion. About 1/4 to half have respiratory symptoms. 10% have sore throat. Lesser percentage have myalgias. They might even have swollen hands and feet, which is like Kawasaki. And they can have lymphadenopathy. And clinical findings, they can present with hypotension. Some of them can have the whole criteria for Kawasaki disease met. Importantly, they can have myocardial dysfunction, which is either picked up by echocardiogram or an elevated troponin T. Now, this is different from Kawasaki disease, where you're looking for coronary abnormalities, not so much myocardial dysfunction. Whereas with PIMS-TS, it's actually myocardial dysfunction. They can have arrhythmias. They can have like an ARDS-like picture requiring ventilation, non-invasive or invasive. They can have acute kidney injury, serositis, which could be pleural, pericardial, or ascites. Hepatitis or hepatomegaly can happen, and in a small proportion, they can even have seizures, coma, and like a meningoencephalitis-like picture. Abnormalities in the bloods, they usually have lymphocytopenia and neutrophilia. They can have mild anemia and even have thrombocytopenia. Now, Kawasaki, they usually have thrombocytosis, whereas here they can have thrombocytopenia. And inflammatory markers are all elevated. CRP, ESR, ferritin, procalcitonin, D-dimer is also elevated, fibrinogen is elevated. They often have elevated cardiac markers like troponin T associated with hypoalbuminemia, which is again albumin being a negative acute phase reactant. Mildly elevated liver enzymes. LDH is may be elevated, and they can even have hypertriglyceridemia. You can sort of think of it as like an inflammatory syndrome where there is a lot of inflammatory cytokines which are actually causing this disease. Now, the case definition for this, CDC has a slightly different case definition. WHO has a slightly different case definition. I'm just going to put the WHO case definition just to not confuse people. So the first thing is its age. It's between 0 to 19. CDC says 0 to 21, but in WHO case definition is 0 to 19. And a fever for more than 3 days. That is different from Kawasaki, where the fever duration is more than 4 or 5 days. Here it is more than equal to 3 days. And any feature of multi-system involvement. That is, it could be rash, bilateral non-purulent conjunctivitis, or mucocutaneous inflammatory signs. Now, these are all common for Kawasaki disease and MISC or PIMS-TS. Hypotension or shock, then cardiac dysfunction. Here, it's pericarditis, valvulitis, or even coronary abnormalities, or finding an elevated TROP-T. Evidence of coagulopathy, which could be elevated PT-PGT or D-dimer.
Hello?
This or toxic shock syndrome can present like this. So either of these also have to be ruled out, and evidence of SARS-CoV-2 infection. Now, this usually happens about 1 to 2 weeks after the onset of infection. Sometimes the PCR may be negative, and what you might pick up is only the serology, which is positive. So sometimes a history of contact with an individual with COVID-19 is also an important feature. So these are this is the WHO definition for PIMS-TS, and all 6 criteria must be met. This is just to give you a flavor of what the differences are between Kawasaki disease and MISC or PIMS-TS. Kawasaki disease in the lower age group, whereas this is in more older age group, older children. Severe abdominal pain is actually an important feature of PIMS-TS, not so in Kawasaki. Myocardial dysfunction is common in PIMS-TS, whereas coronary abnormalities are what are common in Kawasaki. Acute kidney injury is common with this, whereas renal involvement is rare with Kawasaki. TROP-T is elevated because of the myocardial injury, whereas TROP-T is not so elevated with Kawasaki. And inflammatory markers are all elevated much more in PIMS-TS compared to Kawasaki. Platelet count is lower in PIMS-TS, whereas it's high with Kawasaki. Lymphopenia is there with PIMS-TS, and it's not described with Kawasaki. And of course, the association with SARS coronavirus is more stark with MISC or PIMS-TS. So I'm not really going to the management of PIMS TS because that will be touched upon by Dr. EBOR in his presentation. And so I'll just move on with diagnosis of COVID. So how do we diagnose COVID? So by and large, the best way to diagnose COVID right now is actually doing the RT-PCR test. I told you a little bit about the RT-PCR test. It usually checks for 2 genes. It usually either checks the E gene, which will test for coronavirus, and the next gene would be a RDRP gene, which is specific for the SARS coronavirus 2 infection. That's the RDRP region. That's the RNA-dependent RNA polymerase.
RNA-dependent RNA protein.
Yeah. So, so the sensitivity of the test is actually quite high. You may all have already, looked at some rapid antigen tests. The rapid antigen tests basically are also, they also detect viral antigens, whereas the RT-PCR detects the viral genome, the RNA itself. Now, antigen tests are also very highly specific. So which means if you have an antigen test which is positive, it means it is a positive, but its sensitivity is a bit poor, which means it is, if it is negative also, somebody might still have COVID. So what I would suggest is, if you have access to the rapid antigen test, rapid antigen tests are actually most positive early in the disease or just before onset of disease. So if it's positive, you can take it as a positive, but if it's negative, you might still, and if you still consider COVID as in your diagnosis, I think you should still do the RT-PCR test. But RT-PCR, like you know, it requires a PCR machine, whereas the rapid antigen test is a very simple test, which only takes about 15 minutes. It can be done as a point of care test. And it's a very cheap test compared to the RT-PCR test. In CMC, we don't do the rapid antigen test. We only do the RT-PCR test. Antibodies, I have not talked about, because antibody tests will tell you whether somebody has had coronavirus in the past. And it is not a good test to diagnose coronavirus disease at that point. And also, there are no good antibody tests which are very well validated to say whether how good they are. So in CMC itself, we do not actually do an antibody test. Even though it's available for research purposes, we do not do it for clinical purposes. Now, I thought it may be useful to know a little bit about the imaging findings of COVID. I found this useful because there are certain imaging findings which are actually more specific for COVID compared to any other respiratory illness. One, you may not find them in all children. This is a very small proportion which will have children. As far as children go, this is a very small proportion which will have all these signs. But in adults, it is actually a little more common than in children. So if you do a chest X-ray, what is it that makes you think this is likely to be COVID? First is features of consolidation or ground glass opacities. GGO is ground glass opacities. Now, I've just put this X-ray, and there are 3 features which are very typical for COVID. One is that this thing is bilateral. The opacities are bilateral, they are peripheral, and they are more often in the base. And there is no pleural effusion. So if you look at this X-ray, it's peripheral opacities, more in the bases, and it is bilateral. So this is more likely to be COVID. And the pleural effusion is very rare. This is what British Society of Thoracic Imaging Guidelines, which have actually said, if you look at an X-ray and if it's lower lobe, peripheral, predominantly multiple, which are bilateral, that is probable COVID-19 or classic for COVID-19. If you don't have all these features, you cannot say whether the X-ray features are typical for COVID-19. If you have pneumothorax, if you have lobar pneumonia, pleural effusion, pulmonary edema, then it is not COVID. And if you have a normal X-ray, you could have a normal X-ray with COVID-19. It does not exclude COVID. But if you have lobar pneumonia, pneumothorax, pleural effusions, pulmonary edema, these are all rule out COVID. These are just, I mean, I think it may be useful in practice also to think about this. Next is CT chest. Like, I mean, I know a lot of places which actually do CT chest over RT-PCR to actually find out whether somebody has got COVID or not. So what are those features in the CT chest? So there are features depending upon the duration of illness. So early phase, that is 0 to 4 days, the CT could be normal, or you can have only some ground glass opacities. And these ground glass opacities are, like I told you, it's peripheral, basal, and bilateral. When it becomes increased, it causes a crazy pavement appearance. I will show you what it looks like in the subsequent slides. And after the peak stage, it looks like consolidation. And then after 14 days, it's like an absorption. When somebody is recovering, it causes fibrous stripes, and everything sort of resolves in about 1 month also. Now, we don't know what the post-COVID syndrome looks like. I mean, maybe in the next few months or so, we will know what the effects of COVID on the lungs are, but we don't have a good idea yet. So this is 0 to 4 days. You can make out that these are ground glass opacities, which are peripheral, bilateral, and I mean, you can't make out whether this is basal or not, but it should be basal. For 5 to 8 days, the ground glass opacities have become much, much more, and it looks like a crazy pavement. 9 to 13 days, it looks like consolidation, bilateral consolidation with air bronchograms. More than 14 days, when it's resolving, actually there are fibrous strands. So that's what resolution looks like. Okay, little bit about the treatment. I'm not really going to go into too much about the treatment because there is really no good treatment available. So the treatment that we use are primarily steroids. And if somebody has got an elevated D-dimer, then we would give anticoagulation. And in our children so far, I mean, out of the 300 odd children that we have treated, we have not used any antiviral so far. Even though the adults use remdesivir as their antiviral, it's available for use for us, but we've not had the reason to use remdesivir in any of our children. So that's why I'm not really going to talk too much about those kind of treatment. And Dr. EBOR will touch upon those aspects of treatment. So we classify them as mild illness or like asymptomatic. No empiric antibiotic. If we think it's like flu, we might give oseltamivir. You only send them home with home isolation. We don't even test. Now, for mild illness, if they have a risk factor. Now, what are those risk factors? People think that some risk factor might lead to severe disease. So those risk factors are, if you have underlying congenital or acquired heart disease, if you have renal disease, lung disease, liver disease, or hematological disease, or neuromuscular disease, diabetes, or any sort of immunosuppression, people think maybe they'll have severe disease, but we really don't know whether it actually causes severe disease because by and large, even those who've had all these things, many of them have actually gotten better and gone without any problems. But if they become severe, it is more likely that these people are the ones who are likely to have severe disease. So these children, you can tell them to be careful, and if they have any worsening, to come back immediately. And if they have any tachypnea or or if they have any danger sign, that is lethargy, or if they have any seizures, if they have any hypotension, if they have prolonged CRT, if they have any danger signs or any Kawasaki-like illness, I already put the criteria for the MISC or PIMS-TS. If they have any of those things, they need admission. And depending upon how severe their illness is, you give an oxygen you might want to start steroids, and if they have high D-dimer, you might want to start them on anticoagulation and remdesivir if needed. So that's about all that I'm actually going to talk about in treatment, and Dr. EBOR will touch upon a little more on that. Then finally, a little bit about prevention, because I mean, right now it doesn't really look like any of our preventive methods are really working very well. I mean, every day we see about 5,500 to 6,000 people in Tamil Nadu who are actually getting infected with the disease. But if you really were to go after preventive strategies, there are three things. First, universal masking. I mean, everybody has to be on a mask, because like I told you, the bulk of transmission happened due to droplets. If everybody wears a mask, then your probability of contagiousness is actually decreased very significantly. So if the wearer has disease, if you're coughing into a cloth mask, your droplets don't go very far. So you're not really transmitting to anybody. And if you are wearing a mask and if you've got the disease and you're wearing a mask, somebody else who's not got disease also is wearing a mask, then the chance of this transmission is actually considerably reduced. It is like if both people wear masks, I mean, the contagion probability has become 1.5% compared to 70% if nobody is wearing a mask. So what mask should you wear? For if you're going on the street, maybe cloth masks are okay, but in a healthcare setting, surgical masks are advisable. I think surgical masks definitely have an advantage over the cloth mask. And in a healthcare setting, if you're seeing patients, adding a visor really helps. Somebody said yesterday that what is important is what is above your shoulders. If you take care of the space above your shoulders, that's very important. I mean, so if you worry about, so the space above your shoulders, make sure that you cover that. And N95 is not always necessary. Only if you have aerosol generation happening in the place where you are, you need N95 mask. I know a lot of people walk around with N95 mask. So, but it's really not necessary unless you're in an area where there is aerosol generation. That is, if there is suctioning, you're intubating, you're using nebulization, then N95 is useful. Physical distancing. I mean, droplets, I told you, it falls less than 6 feet. WHO says 3 feet. Various people, anywhere between 3 and 6 feet. So if you wear masks, maintain distance between people of at least 6 feet, that itself will actually prevent the spread. I mean, these are all easier said than done, as you can imagine. I mean, you can go around in the streets and see how things are. So, but if you really want to control the epidemic, I mean, these are things that will help. And finally, hand washing. I told you about the lipid envelope in the virus. If you wash your hands with soap, the virus just disintegrates. So even if there is a fomite transmission, if you touch somewhere and if your hands are contaminated, if you wash your hands with soap or even use hand rub, your virus gets deactivated, and that's enough. So these are primarily the things that are useful for. So 3 things: universal masking, the maintaining a physical distance, and hand washing. Now, if you sit in a crowded area, if you go in a closed space, your risk of transmission is much higher than if you're in an open space. So I'll conclude now. So in conclusion, COVID-19 is caused by the SARS coronavirus 2 virus. The virus is called severe acute respiratory syndrome coronavirus 2. And the disease it causes is the coronavirus disease 19. It's an RNA virus. It causes less severe disease in children. But MIS-C or PIMS-TS is an important manifestation of COVID-19 that occurs specifically in children, which needs to be recognized because they can become really sick and their treatment modality is actually quite different. There are chest X-ray and CT findings which are very indicative of COVID-19. Treatment-wise, there is really no good specific treatment that is very useful. by and large, treatment is with steroids, anticoagulation, and antiviral. The one antiviral that we use is remdesivir right now. Prevention is by universal masking, physical distancing, and hand washing. And I did not tell you anything about the vaccine because we really don't have a good vaccine right now, which can come into the market very soon. I mean, we might find something in a few months, but not yet. But remember, no like respiratory viral vaccine has ever been so good. Like influenza vaccine, I mean, it's not a great vaccine. It can prevent to a certain extent, but it is not going to be like a measles vaccine or a mumps vaccine where it will be very effective. With that, I will stop. Thank you for your patient listening. I'm okay for Dr. EBOR to continue, and then we can both take questions at the end. Is that okay, Dr. Geeta?
Yes, sir. Sure. Sir. So can he introduce, sir? Dr. Saravana Kumar will introduce Dr. EBOR, sir.
Can I share my screen?
Yes. Yes.
Okay, I will stop sharing my screen.
Thank you, sir, for enlightening us.
So they have to enable me to share my screen. Dr. Geeta, could you please tell the person?
Mr. Prem? Mr. Prem?
I think I can share.
Okay, sure.
Are you able to see my screen?
Yes, we can see there are 114 slides.
Yeah, that's right.
Yes.
So unedited, so I can stop anywhere you want. That's the introduction I would want to say. Okay, shall I go ahead?
Sure, sir. Sir, introduction, sir, by Dr. Saravana Kumar, sir.
Yes, ma'am.
Not quite, sir.
That's okay. Right. Okay. So,
Okay. Yes, sir.
On behalf of Ranipet IMA, I welcome Dr. Professor EBOR Jacob, sir. He is currently professor and head of pediatric critical care unit at CMC VELLORE. Sir completed his Diploma Pediatrics in CMC VELLORE. Later went to Australia in 2005 and worked as a senior registrar in pediatric intensive care unit at Children's Hospital, Westmead, Sydney, and then did his fellowship in pediatric ICU and cardiac ICU at Great Ormond Street Hospital for sick children in London. Returned back to CMC VELLORE and now currently working as a professor and the head pediatric critical care unit CMC VELLORE. Sir was also the IAP Nataka chapter president during the year 2017 and 18, and he is also currently serving as an executive board member of IAP Tamil Nadu. He is a regional faculty in American Art Association and is also coordinator and facilitator for many various IAP modules. And he is an examiner for UG and PG students in Tamil Nadu, MGR University, NTR University, Andhra Pradesh, and Rajiv Gandhi University for Medical Sciences and Pondicherry. And he has also authored many national and international clinical and research papers, and it has been published in various journals and conferences. Sir also received Dr. V. Balagopala Raju Active Pediatrician Award in the year 2017. And with this, I hand over the mic to Dr. Professor EBOR Jacob, sir. Thank you, sir.
thank you, sir. Thank you, Dr. Geeta and the IMA Ranipet for inviting us for this. So I'll just go into the talk as the major talk is by Dr. Winsley Rose. Yeah, although I have 104 slides.
Sir, you can continue.
That. Are you able to hear me?
Yes, sir. Yes, sir.
Sure. So the scope of my talk will be about the spectrum of disease which we see in our ICU. And I just wanted to put the word essential care of acutely ill children. So that is more important. I thought probably as we see many children during this COVID, we may not see many of them coming to hospital, whoever they come in acutely ill or need some optimal care pre-hospital state. and some infection control practice and MISC critical care issues, which Dr. Winsley has already pointed out. So I can skip many slides. And as you were saying, the treatment part, as we know, I don't have any experience with remdesivir or other drugs. Only I will stress about the essential and quality care of critically ill children. So this is, as we know, in adults, 80% is ambulatory. That means asymptomatic, and 15% require some essential care, and 5% come to ICU. That mortality depends on. This is our rough data till the end of August. And we have got about 213 children who are suspected to have COVID, and they're sick enough to be in an ICU. That were about 213. Others, about 205 children has gone to the ward. And overall positive, we had 280. That means out of, this is not very clear, accurate number. So 418 children among screen, 288 were positive, 69%. But as Dr. Winsley said, most of them are asymptomatic. So that means it is 34 children only with positive, COVID positive, we required some ICU care. That's about 11 to 12% only. And we had one death and one DAMA. That child also had some cardiac illness, which is well, and they need other surgical treatment, so we went to the other hospital. So the mortality rate was about 2.9%. And among the age and the gender is under 5 is about 18, and others are like 10 and about 10 years, and 6 to 9 years, about 6 children. So this is almost coincide with this AAP news, which is this morbidity and mortality weekly report by the American Academy of Pediatrics. There's 33% of children hospitalized with COVID-19 admitted to ICU. Ours is probably more lesser than that. And comparatively, just you need note this alone, 8 per 100,000 compared to 164.5 per 100,000 of adults. So the overall, the burden is less, but our spectrum is totally different, as Dr. Winsley has pointed out. This is about an ICU study in North America. Here, I just the asymptomatic, more of severe and critical, but I'm not going into the detail. I want of time, so I'll skip that. So the spectrum of COVID-19 disease in ICUs, we are divided as per the WHO and our protocol. For moderate disease, we have a definition. That means the patient has a pneumonia. That means as per ARI control program, you have respiratory rate being a guideline, tachypnea, without what danger signs you call it as a pneumonia, or a severe disease if they have a pneumonia criteria with danger signs. What is danger signs? General cyanosis, saturation is still low with the respiratory distress with some abnormal breathing or airway sounds, or any other general danger signs. Critical disease, we are defined as worsening of oxygenation or respiratory failure needing intubation, or when they come across the fulfilling the criteria for ARDS, which is called acute respiratory distress syndrome. And we have pediatric, which we have separate definition, probably I will show it later. And this is the same mild, moderate, severe, critical as per the WHO. The critical involves not only the ARDS, it involves shock and multi-organ failure, more than 2 organ failure. So these are the presenting features in our ICU. As Winsley was pointing out, pneumonia was very less, 4, but most of them had shock. But this shock also is not profound, but some of them had profound, but most of them.
இந்த Zoom meeting பாருங்க நல்லா இருக்கு CMC
moderate
பாருங்க
moderate fluid responsive. Can you somebody mute this? Okay, fluid responsive, and some require catecholamines is a moderate or mild doses only. And the cardiac infection dysfunction were in 9%. These were overlapping, most of the symptoms are, and presenting features. Severity of categorization, as I said, I had 34 children who come into ICU. Among that, only moderate to severe disease, that as per the definition which I showed earlier, 12, that is 36%. Critical, which involves PIMS TS, then it will become around 64%. PIMS TS, as Dr. Winsley said, is pediatric inflammatory syndrome temporarily associated with COVID. That's as per the WHO case definition, which are fitting into. Critical disease means they are severe shock or myocardial dysfunction, and very few had say, respiratory failure requiring non-invasive or invasive ventilation. This is the same. And investigation wise, we do inflammatory markers like ferritin, CRP, SR, procalcitonin, and coagulation parameters, D-dimer, which we never used to do in previously, particularly children. And but nowadays with COVID, which is extrapolated from the adult world, we started doing that. But actually, we don't know how to interpret and whether we have to give anticoagulation. Cardiac markers were raised in some of them, but clinically they were evident as well by echography or echocardiography and other parameters. Some underlying associated illness these children have, which I have put it there. And then treatment-wise, ventilation is only 3. That is 2 children were invasively ventilated. 1 was non-invasive ventilation. Most of them is HFNC, what is called high flow nasal cannula therapy, which is giving a physiological flow through a same nasal cannula, which most of you would have been using. And vasoactive agents, about 18 children received. 13, we have given this dexamethasone, steroids we have given, and 2 children have received IVIG. About 13 children have received either unfractionated heparin or eclexane. So duration of stay was mean of 4 days. And outcome, as I told, there was 1 death and other children, 1 child went for lymphedema. I quickly touch upon just a presentation of the child with respiratory distress, little bit on ARDS, I will not go into detail, and some about shock management, and that's the PIMS management, and I will complete. So this is a 4-year-old girl presented with possible contact with COVID, fever for 3 days, fast breathing. These are the parameters which I put as tachypnea for 4 years 50, and saturation is 88% with recessions. Blood pressure and other hemodynamics is stable. So how do you approach? I'm not asking anybody to answer. So this is always I go and I always insist, and all pediatricians know that we have to go by the PALS approach. What we go like a systematic assessment. We'll go by the pediatric assessment triangle, and then we will go by the ABCD primary assessment and come to an identification of the problem and intervene. So what does that mean? At the end, you will come across a physiological status, which is very, very important for an acutely ill child. Unless you stabilize, your diagnosis is not going to work. Means unless the child won't be there to treat the diagnosis or the etiology. So both has to be hand in hand. Physiological status is very important. At the same time, you need to think about your possible diagnosis. So in this child is in respiratory distress, as you know. Child is tachypnic with subcostal and intercostal retractions, hemodynamically stable. So we may say probable pneumonia, severe acute respiratory illness in relation to this COVID. So we admitted this child. I will skip this video, and this is the X-ray of this child. As Dr. Winsley was saying, there is no effusion or anything, so it has got some consolidation or probably a ground glass appearance. We cannot say much in this X-ray, but the child was saturating low in the room air. We started on face mask 5 liters oxygen, and the saturation was coming up to 90%. This is the venous blood gas, which PCO2 is 54. Okay, PCR was positive. So can I ask these 3 questions? Is this information useful in directing further therapy? A child who has got a respiratory distress, probably a pneumonia, a COVID-19. Or does this child fit into this ARDS criteria? Which therapy would you start? Although we have seen their respiratory involvement in children is much lesser in COVID, in other diseases also it will be useful if you go by the systematic assessment. So this is the pediatric ARDS definition, which is mainly by the age and the timing, that is acute should be less than 7 days, and mainly by the oxygenation, non-invasive and invasive test. So we need to have one criteria called PF ratio, that is PaO2 by FaO2 ratio. That we need to have a blood gas. Most of the secondary hospitals are in the primary, you may not be there. So can we use this criteria? Yes, we can. That's what they put, what is called as SF ratio, that is by saturation. Pulse oximetry is everywhere. And FiO2, you need to know either by a blunder or approximately we can calculate. I will tell that about in another few slides. So based on that, we will define the ARDS. This child fits into that. So as I told you, PF ratio, if you don't have, SF ratio is a very good surrogate marker. It has been proven by lots of studies as how it has been useful effectively in a secondary hospital setup where we don't have a blood gas to analyze. So in CMC also, we have done a study and proven its correlation, and it is very well correlated, but we have to get to do a validation in ARDS patients. So the case scenario is continued. So as I told, the child is on a file test 40%. The answer to question, yes, we can useful directing the further therapy. SF ratio for this child is 225. If you remember the criteria, say less than 260, it will fall into the criteria what is called ARDS. Maybe the severity differs, mild, moderate, and severe. It will alert you. This, my patient falls into that. So I have to be closely monitoring this child. How can I upgrade the respiratory therapy? At what point I should refer this child? Does this file, as I told you. So which therapy would you start now? The child is already on a 5 liters. That's what I said, approximately 40%. So, and how did I come across this 40%? This is a fair bit role, but it can be used in many situations. That means we are breathing at 21%. If you give 1 liter flow, that increases by 4% above your room air. That's 25%. If it is a 5 liters, probably for 20%, it will be more. That will be 21 plus 20, 41%. So this is fairly, we will give you an FiO2 if you do not have a air oxygen blender, which will show you the fractional inspired oxygen, otherwise FiO2. So here in this child, we used a mask, nasal mask, and then not nasal, the Hudson mask, and then it's been moved to HFNC. So these are all, so many devices are there, but I'm not going into that in detail. So I just wanted to just stress upon what is this HFNC. Many of you may be using. In children, it started first, and in adult world also, everybody is using, especially in this COVID era. It helps a lot in the mild to moderate disease of limiting the respiratory involvement. This is the mechanism which it works. You can easily remember by remembering the mnemonic high flow, heated and humidified. We are giving a supra-physiological flow, so you have to heat it extra and give humidification. It has to be more than your inspiratory demand of your lungs. Inspiratory demand, the flow has to be more than that. That's what we give, quite a bit of flow. To meet the functional residual capacity, it is lighter. That means it's very friendly. It's not suffocating like your non-invasive or other types of hood or something, which is maybe claustrophobic effects for some of the patients. Oxygen dilution is decreased because the concentration increased. The other important point is wash out the dead space, fills it with oxygen, which is very useful. And these are the things I'm not going. And these are the different machines are there, but some companies monopolizing in it. But we can use it with even indigenous usage of some units use that, but I don't have time to explain that. How much flow to start? So usually we'll do 2 liters per kg per minute up to the first 10 kilos. Then you can add 0.5.
এত ভালো কোভিড ওয়েবিনার আমার সারা জীবনে হয়নি, এটা ভেলোরের কোভিড ওয়েবিনার।
Okay, so then otherwise approximately you can have 3 times your minute ventilation. What is that minute ventilation? You calculate the tidal volume, that is 6 to 8 ml per kg, into the respiratory rate with the patient is breathing at. That will give you the minute ventilation. So about 3 times the minute ventilation is usually approximately, I go by that. Otherwise, you can follow to check. There are some contraindication, especially the level of consciousness is low, you may not use it. And if there is child is severe hypoxic, you cannot use it. So this is your low flow nasal canal oxygen therapy. You can go for it. Does not replace your non-invasive. So please remember, it does not replace your mask or nasal pillow non-invasive therapy. It is an intermediate. These are the guidelines which even Society of Critical Care Medicine of America as well as European guidelines support this. This is what I was talking about in developing countries which we can use, and flow coming from the source, patient, and the expiratory or limb. We can have one limb which is underwater, which might give some. So this is which is maybe a finely refined and been given as high flow. So many units try to use this indigenous way of using a CPAP or a high flow nasal cannula. Otherwise, the next step I told you, the non-invasive ventilation, there are many methods of doing it. Even in adults, they do with a big hood and face mask tightly fitted. What does it do? Without CPAP, you see this alveoli is collapsed. With CPAP, it is fully inflated, which helps in the ventilation perfusion mesh. I'll flip that and this also. So when a child is being intubated, certain things we need to remember. We have to use a PPE, full personal protective equipment, especially a visor or a goggle, which is necessary. These are some of the boxes which you used, but it's not very practically helpful. But you need to have a good seal so that the air leak is minimized when we are bagging. And also there is a viral filter which we recommend for doing bagging. This is which I pointed is showing it, which helps in, we believe it helps in preventing much release of virus. And this is a patient. Okay, so just a minute about how, whether they generate aerosol when we start oxygen. Dr. Winsley talked about the how does it spread and everything. And when we start, you see, this is in a human patient simulator. They have done the studies. And even with a simple oxygen, 0.22 meter, there will be aerosol generated. In nebulizer, it is more. If you are using a severe in a lung injured child, you will have a 0.8 meters where aerosols can flow and disperse. So what we say, try to avoid nebulizer, use metered dose inhalation in case if you need to use any short-acting beta-2 agonist. What about in HFNC? It is also same. That's been done in some simulated mannequins, and it has some spread. Initially, people were saying there was a debate whether to use NIV or HFNC, but now we use everything in every ICU, both in HFNC and NIV, because it is almost similar to other modes of giving oxygen delivery. So this is a good thing which you can see. This is from SICKIT. See, this first picture shows a HFNC. It's also in mannequin with a 10 liter minute spontaneous respiration. That's not much is seen. This is 25 liters with spontaneous respiration. This is 25 liters with simulated cough. If the patient is coughing, you see the patient is dispersing quite a lot of aerosol. Here they found, they put a face mask or a Hudson mask. They found the simulated cough, and even with the 25 liters, there is not much of dispersal of this aerosol. So we would advise giving some mask over a HFNC, or even a surgical mask will be helpful. So I'll skip all these things. So the patient on an NIV, if is not doing well, will go for intubation. So intubation has a lot of strategies. I am not going into that because it's not a critical care PME. What we call lung protective strategies, which are, there are many things that come up, and like baby lung concept, open lung concept, so many things are there. And basically we have to ventilate in the safe window, which is saying as a green zone. But one thing is very important, the prone ventilation, even in adults, they are saying it is very important, as this COVID, as Dr. Winsley clearly pointed out, even in CT as well as in X-ray, the dorsal segments are more involved. So this prone ventilation definitely helps, but it may be very difficult in obese or overweight adult to put them COVID. They say even if the patient is on a high flow nasal cannula or on oxygen, proning themselves, it helps improving oxygenation. It has, because it has a more uniform distribution of aeration in the dorsal segments of the lung. So another just case, in another 3-4 minutes, I'll finish. So this is a fever, 3 days, vomiting at a GTCS, but this child is hemodynamically unstable. He's a 5-year-old child. And so this, as I told, his physiological status will be hypotensive shock. So etiology, you may say fever and a seizure, probable sepsis or an acute CNS infection. Any situation, even if it is COVID or non-COVID, you might have to use your guidelines, the best practice, infection control practices. But you have to follow the, what is, I put it is here, the time-sensitive, goal-directed therapy for sepsis. Sepsis kills, that we have to remember. So it is sepsis in mortality in a very good center also, it is 40 to 45%. So unless you recognize and give treatment as per this, like what we say is oxygen, fluid bolus, as well as culture and broad spectrum antibiotics within the first hour. So that is very, very important to get a good outcome in sepsis rather than coming long way and treating a severely ill hypotensive shock. So in a secondary hospital, so it's all very preliminary, which is available. Just give oxygen, just get a line, get some culture, give antibiotics and fluid bolus, the child may do well. So this child, day 2 as PCR was positive. I said this child is hypotensive shock and this child's inflammatory markers are high. And we sent this myocardial troponin also is high. D-dimer was 7,201. And we did an echo, we showed ejection fraction of 40 to 45%. So this child presented with PCR positive fever, hypotensive shock with myocardial dysfunction. So this myocardial dysfunction, we go separate. So the hypotensive shock, we manage.
obese they'll have some amount of
So as I mentioned in this algorithm, the SARS
will help.
You might give oxygen, high flow oxygen, and you might try to get an vascular access, take culture, give fluid bolus accordingly, 10 to 20 ml. But you have to be reassessing these children, whether there is fluid overload as well. What fluid do you give? Always give isotonic crystalloids, never hypertonic or hypotonic. That means half normal saline or a dextrose containing fluid. And antibiotics also is a very, very important thing in your first hour. Like that, we manage this patient. For the myocardial dysfunction, we give some inotropic agent and respiratory support in the form of non-invasive or HFNC, and then upgraded to non-invasive. So this child, on the day 4 to day 5, we noticed this sort of rashes and the cracked lips. You could see this. And some erythematous rashes as well in the legs. So what is this? This child PCR positive, hypotensive shock, myocardial dysfunction, and has some rash. So mode of presentation, we know, as initially I said, they are presenting a respiratory or shock. And this child has myocardial dysfunction, rash, inflammatory markers are high, and there's an abdominal edema. So that's what comes into, as Dr. Winsley clearly explained about what is the PIMS and MIS related COVID-19. And as he was saying, in many terminologies, many definitions, and different spectrum also is emerging. Some people or rheumatologists say is febrile children with inflammation and temporally associated. Some are incomplete Kawasaki-like diseases, or some without that Kawasaki features. We call it as pediatric inflammatory multi-system syndrome, which is temporally associated. This is all from May onwards. We know about this. Initially highlighted in UK and then US, and is being published. So actually, we don't know much about that. We are all saying in different, and probably we are seeing the tip of the iceberg, and we are yet to know a lot of things about this. And WHO definition, which we follow, Dr. Winsley explained about this. But we have different definition. Only common among all definition is fever, and that should be evidence of rise of inflammatory markers and multi-system involvement, like GI system or a heart or a hypotension, and exclusion of other potential causes is very, very important. So relationship with SARS-CoV, whatever described in the literature is, so they come after about 3 to 4 weeks later of their first COVID-19 infection. They may not have PCR positive, but their serology is all positive. You could see these studies, which shows PCR is not much, 20-25%, and all of them have serology positive. This is our experience. Our 8 children we had, most of them are, 5 of them are 5 years and older. So that is one is differentiating from Kawasaki disease, as Dr. Winsley clearly said. It's less than, it's more older age group. And their inflammatory markers were raised. Some of them had rash, or a couple of them had some rash. One is a typical rash at day 5 to 6. And all of them had some, as I said, inflammatory markers are raised, and they had myocardial dysfunction with markers, but we not done for any of all of them. When they have any symptoms, then we did the and D-dimer also, which was very high, but we don't know really we have to interpret clearly. But we have started on anticoagulation for sick children. That means if they are in shock, we have started them on unfractionated heparin and later on to Glaxane or enoxaparin. So now we are having one child in this week who has got he's a 14 years old with fever of 1 week, who presented in hypotensive shock, some pneumonia, myocardial dysfunction. Mother had COVID in July, but his PCR is negative twice. He was put on ECMO, and he's by God's grace is out of ECMO now. So he has to come out of the ventilator. We have sent the serology, as Dr. Winsley mentioned. We are not doing serology here. We are storing it for as a study purpose. Probably will they. This child also probably fitting into this what is called the pediatric inflammatory multi-system syndrome. So to conclude, I'll just brush upon all this just to highlight severe COVID illness in children is significant. It may be far less than adults, but we need to identify. The burden may not be that much as in adults, but we have to give quality essential care in the initial time. What I mean is identifying or recognize them in their respiratory systems, symptoms and danger signs, and then appropriately manage. And I just want to add an SF ratio, which is an important tool, which can be used in secondary hospital setting to identify this, what is called an ARDS, and escalate your treatment. Best infection control practice is a must when we are using or related to all these aerosol generating procedures to protect ourselves. And I just mentioned about our experience. Among all, about 12% of the children require intensive care, and shock is more common, but it's not profound, except a few children, and some of them presented like MISC or the PIMS-TS, about 8 children, and all of them had shock. And overall mortality is very low compared to one child died, that's about 2.9%. Thank you so much, and I thank my PICU team who really worked hard during this time. And thanks to my multidisciplinary team from ID as well as rheumatology. Thank you so much.
Thank you, sir. Thank you for the very elaborate and very informative session both of you have given us. So would you like to have some question time also, sir? Question time? Hello?
Winsley.
Yeah, yes, ma'am. I think if there are any questions, I will be happy to answer.
Yeah, if you have any questions, please. You can.
Good evening, sir. This is Dr. Srinivasan.
Yes. Yes, sir, tell me.
Sir, my question is regarding the asymptomatic people have a very less droplet generation. So will they able to transmit as much as symptomatic people?
So, I mean, see, these things are all not very clear. What we know is asymptomatic people also, the viral load is as much as the symptomatic people. But since they do not cough, I mean, actually, even speaking loudly, singing, shouting, all of them can generate aerosols. So it's not only like, you know, it's not that you have to cough or sneeze to generate aerosol. So even if you are asymptomatic, you can still transmit.
Right. Okay. Thank you. Thank you, sir.
Yeah.
Good evening, sir. Good evening, sir.
Good evening.
Yes.
Good evening. Can you hear me?
Ma'am, speak up. We can hear you.
Can you
Please speak up. Yeah, we can hear you. Please speak up.
Hello.
Yes, ma'am, we can hear you. Please ask your question.
No, it's for Dr. Winsley.
Yes.
I know it's yeah. So I know it's too early to ask, but I would like to know something about reinfection, sir.
Like, I mean, if you actually look at literature about reinfection, every now and then there is one case report of somebody having been reinfected. But if you look at the number of people that have already been infected and the number of cases that are being touted as reinfections, it's extremely, extremely small. And reinfection might happen, but it may happen at a time, maybe not so early. It might, I mean, for reinfection to have significant disease, it probably will take time. I mean, not a few months. It may be, I don't know, maybe some more months and you might have a reinfection which is severe. But I personally don't believe reinfection is a big deal. I mean, you can have reinfection, but I don't think it will cause significant disease. Not yet, at least.
Any other question?
There is a question here, Winsley. There is the role of flaviprevir, what is that? Flaviprevir in pediatric patients.
So we've not used favipiravir. I mean, we have access to remdesivir. I don't know whether favipiravir is any better than remdesivir. I mean, even the sick ones, like you've already, Dr. EBOR mentioned, we've not, even for the sick ones, we did not use remdesivir, and the outcome was no real, not any different. So we don't have experience with favipiravir.
We just use dexamethasone and some heparin, Lexine. That's all.
Hello? Any other questions? So this is to Dr. EBOR, sir. Hello, sir.
Yeah.
All the children that were admitted in your ward, like 300 children, you said you saw COVID positive patients. All of them had a positive history, sir, from the adults in the family?
That is 288, about 300, as Winsley mentioned. Most of them in the wards. Winsley, do you have any answer for that?
So we have not analyzed that yet, but like you said, madam, I mean, most of them have somebody they've been in contact with. It's some family member who's often positive.
Yeah,
there are very few patients. Yeah, very few who don't have a family member who is positive.
What is your advice to pediatricians and general practitioners, sir? When we say children, most of them with very mild illness, how to protect ourselves? Because most of the time it's very difficult to maintain the social distancing. Have to examine them a little closer.
I think it's important to use a mask, and a mask plus a visor, like a surgical mask plus a visor is effective. That's what that's what CMC, we recommend using a surgical mask and a visor in all outpatient areas. And using a mask on a small child, actually WHO says not to use a mask less than 5 years of age. CDC says less than 2 years of age, not to use a mask in less than 2 years of age. But I mean, I guess we just have to, as much as possible, distancing, and we should use a mask. I mean, it's important to remember that above the shoulder protection.
But if you are giving any nasal cannula oxygen, I think we should give some, they may not keep it, but it's better because it might produce aerosol generation. And there are simulated mannequins, they have proved it reduces the generation of aerosols.
Yeah, I'm just saying in OPD setting, it may not be, yeah.
Any other questions? Any other questions?
Sir,
actually
this,
now,
hello?
Yes,
Srinivasan.
Sir, role of Clexane after discharge of patients, sir?
I'll ask Dr. EBOR can answer that maybe.
So we are yet to know about that. That's what we are planning to study. We used to stop at the time of discharge. If the patient, see, we are not treating the D-dimer as such fully. I don't know, the Winsley in the wards, you are treating differently.
No, we've not.
When they are in sick, that means oxygenation requirement is high or requiring fluid ball shock. Then we put them on this Lexane till they are discharged. But we are not continuing afterwards. And we try to do this D-dimer every 3 days, and then we are seeing the trend of coming down. Even the next day, if you are doing from 55,000, it's just come down to 3,000 or something. So, but we don't know the actually about this D-dimer. So we are planning to see how it works.
Okay.
Are you also planning for any follow-up of these children, sir, like long-term studies? Because this is a new illness for the long term. You're doing any study to follow up these children, especially the critically ill ones?
Yes, critically ill. Yes, we have written up on, and we are planning to follow them up. Yes, all those who are requiring some sort of respiratory support and was presented with this whatever the PIMS, TS or MISC. Yes, we are planning to follow them.
Any other questions, sir?
Hello, sir. Hello, sir.
Yes.
Sir, in many institutions, the ivermectin tablet 12 mg for 3 days given to adult patients, sir, adult COVID positive patients. Is there any role of ivermectin in pediatric cases, sir?
So we are actually doing a study on ivermectin. We don't have enough data yet to say that ivermectin really works, but we don't use ivermectin or any other drug actually. The only drugs that we use are steroids and anticoagulants. We have not used any other drug to treat COVID. So yeah, but there is a study going on also. Even in our institution, there is a study going on with use of ivermectin.
Okay.
What about supportive therapies,
Can we
sir?
give the
Other things?
ivermectin to pediatric cases, sir?
Sorry?
Sir, can we give the ivermectin tablet to pediatric cases, sir?
So, I mean, there is not much evidence yet to say how effective it is. Yeah. So, but it can be given. I mean, it can be given. It's not a very toxic drug. So.
Okay. Thank you.
Thank you, sir. Thank you, Dr. Winsley, sir, and thank you, Dr. EBOR, sir. Thank you for spending your valuable time on a Sunday evening and giving us a very informative session, and also for all the latest academic updates. We are already groping in the dark, and we wish many more things come up so we are able to manage our patients well. Thank you so much, sir, once again. And
thank you.
Now, thank you, sir. And also now there's a brief talk about typhoid fever, sir, because our sponsors are vaccine people. If you don't mind, I can just brush through, sir.
Is it okay if I leave, madam? I'd love to.
Yeah,
go.
sure, sir, sure.
Thank you so much.
Yeah, thank you so much, sir. Thank you. Thank you. Can I? Actually, good evening. This is not going to take much of your time after the very nice topics we have been listening to by Dr. Winsley Rose and Dr. EBOR Jacob. We all know about typhoid fever. Almost every day we see these cases. We shall just brush through a brief summary about typhoid before we go into the vaccines available now for this fever. Mr. Prem, the slides, please.
Yes, madam.
Next slide. Next slide. Now about the etiology of typhoid fever, as we all know, this is caused by, this is also known as enteric fever. It's all mainly caused by the bacteria. There is a gram-negative bacilli, Salmonella typhi, and Salmonella paratyphi A, B, and C. And the ratio being the disease caused by Salmonella typhi and paratyphi is 10:1. Next slide. Next slide, please. And epidemiology, we have it's a community study done in urban slums in Delhi, shows 980 people affected in a group of about 1 lakh population. This is the incidence, and fevers lasting for more than 7 days should be investigated for typhoid. Now, the spread of typhoid, how does it spread? Now, it mostly, it's a fecal-oral route, as we all know, through contaminated food, water, and also milk products. Like we say, the following are the ways in which typhoid spreads, that is contaminated food or water supply, especially after floods and natural disasters, food outlets with poor hygiene practices, and even eating seafood from a water source contaminated by infected feces or urine, using a toilet contaminated with bacteria, not washing your hands, eating raw vegetables that have been fertilized with human waste, and contaminated milk products. Next slide. Now, a brush through the pathophysiology. The bacteria ingested through contaminated food, it invades the intestinal mucosa. It is taken up by the macrophages and it is transported to the regional lymph nodes, that is the mesenteric nodes, and through the lymphatics to the reticuloendothelial system tissues of the liver, spleen, and bone marrow, and lymph nodes. And there, while they are still inside the macrophages, they continue to multiply until some critical density is reached. And this is actually what happens in the incubation period, which is about 1 to 3 weeks. Then they induce macrophage apoptosis and they break out into the bloodstream to invade the rest of the body. And this is a phase of bacteremia when fever occurs. Again, the bacteria invades the gallbladder, biliary system, the lymphatic tissue of the bowel and multiply in high numbers. And they are now released in the stools again. Now the next slide, the clinical features. The clinical features, as we all know, it's a high-grade fever, headache, anorexia, a coated tongue, which indicates toxemia, then vomiting, diarrhea, constipation, abdominal pain, which indicates intestinal symptoms. But all the symptoms may not be in the same patient. These are all seen. And hepatosplenomegaly, which indicates the reticuloendothelial affection, and rarely ileus and intestinal perforation, which occurs in the 3rd week due to the necrosis of the Peyer's patches. And about 9% of cases, even jaundice is noted because of involvement of the biliary tract. Next slide. Now we go into the symptoms, which as seen in the figures, it is quite obvious. Like we have the toxic symptoms because of the bacteremia and the GI symptoms. So high fever, headache, weakness, a dry cough sometimes, abdominal pain, constipation, and also in 30% of cases, rashes are noted. These are typically called the rose spots, which occur between the 2nd and the 4th week of illness, especially in untreated cases. And they are actually small red spots seen on the abdomen and the chest. Next slide. Now the complications. Actually, when identified early and detected adequately, it is uncomplicated. But complications do occur in the presence of some predisposing factors in a small percentage of cases. Like we have in the central nervous system, those patients' risk factors being malignancy, endocarditis, cardiac congenital heart disease, and all those can also have affection of the complications involving the CNS, like encephalopathy, cerebral edema, subdural empyema, cerebral abscess, GB syndrome, seizures, and meningitis. And those with cardiac abnormalities are also predisposed to cardiac complications, which is about 1 to 5%, like endocarditis and myocarditis, and also involvement of the pulmonary system, about 1 to 6% in the form of pneumonias, and also bone and joint involvement, which occurs about less than 1%. Next slide. And hepatobiliary system occurs 1 to 2%, and also genitourinary system less than 1%. And soft tissue infection in the form of psoas abscess, especially in diabetics, gluteal abscess, cutaneous vasculitis, and so on. Next slide. Now the diagnosis. Next slide. Now we have for diagnosis of typhoid fever, we have the specific test. That is in the first week, it's a blood culture, which is more suggestive, 90%. And the second week, blood culture, feces culture, and Widal test. And the 3rd week, it's a Widal test, which is more suggestive of the antibodies. That is 80 to 100%. And rarely we do the bone marrow aspirate to confirm, but it is difficult and it is invasive and cannot be done as a routine. Now the other tests for supportive evidence, we have the CBC, and usually it shows, next slide. Next slide. Next slide. Other tests like CBC, which shows a leukocytosis, eosinopenia, and thrombocytopenia. Next slide. And liver function also sometimes is deranged because of involvement of the liver, that is elevation of SGOT, SGPT, and alkaline phosphatase. And this happens especially in the 2nd or 3rd week of typhoid. And jaundice is detectable in 9% of the cases. And now we have the treatment columns. We have uncomplicated cases. In uncomplicated cases, usually the fully sensitive cases, we use chloramphenicol and amoxicillin. Chloramphenicol 50 to 75 milligram per kg per day in divided doses. Amoxicillin 75 to 100 milligram per kg in divided doses. For all this for 14 to 21 days, depending on the response. And multi-drug resistant cases, we use fluoroquinolone or that is ofloxacin or ciprofloxacin or cefixime. Cefixime is 15 to 20 milligram per kg in divided doses, and fluoroquinolone 15 milligram per kg in divided doses. And quinolone resistant cases, we give azithromycin or ceftriaxone. And azithromycin 8 to 10 milligram per kg divided doses for 7 days or OD dosage also. And ceftriaxone can be given IV 75 milligram per kg in divided doses 10 to 14 days. And in severe typhoid fever, it's the same. Fully sensitive cases, we use fluoroquinolones. Multi-drug resistant, we also use fluoroquinolones. And quinolone resistant, we use ceftriaxone and cefotaxime. So the next slide. And this mainly this topic was to highlighting about the vaccines that are available now. And actually there are 4 types of vaccines. One is the whole cell inactivated vaccine, then the VI capsular polysaccharide vaccine, and VI conjugate vaccines, and the live attenuated vaccine. Next slide. This whole cell inactivated vaccine is one of the older ones. They were available ever since 1890, but the efficacy is only moderate, and it has a high level of reactogenicity, headache, and severe local pain, which made them to it caused them to be discontinued. And the next slide. And then we also have this live oral attenuated vaccine. This is an oral vaccine, that is TY21A, but this is not available in our country. What is more important now, we have the VI capsular polysaccharide vaccine and the VI capsular polysaccharide conjugate vaccine. So these are what we use now. And what is the difference that we need to know? Like VI capsular polysaccharide, it contains a highly purified antigenic fraction of the VS antigen of Salmonella typhi, which is actually the virulence factor of the bacteria. And the dose is 25 micrograms of purified polysaccharide in 0.5 ml of phenolic isotonic buffer. And the dosage, it is given 0.5 ml intramuscular. And the vaccine is usually stored between 2 to 8 degrees centigrade and is stable for 6 months at 37 degrees centigrade. And for 2 years, it is stable at 22 degrees centigrade. Next slide. And a single dose of this vaccine, actually, it prevents 2/3 of the cases in the first year of vaccination. At the end of 3 years, it has an efficacy shows only about 55%. And a single dose is given at 2 years, and the revaccination is done every 3 years, because after 3 years, the efficacy is reduced and the antibody titer has to be boosted up. And these vaccines, the difference is these are T cell independent vaccines, because if it is T cell dependent, it will stimulate the production of memory cells. So the memory cells are not in this, and these only they are not very effective below 2 years. They cannot be given below 2 years also. So it needs to be given every 3 years, and the efficacy is not good. So now we have the latest vaccine. Next slide. That is a newer generation vaccine. That is VI capsular conjugate vaccine. The difference here is, here the antigen is the same. That is a VI capsular polysaccharide. That is a virulence capsular polysaccharide, but it is conjugated to a carrier protein. So once it's conjugated to a carrier protein, it has a better efficacy. In that one thing, it not only produces same effect as the polysaccharide vaccine, that is it increases the B cells and stimulates them to produce plasma cells, which produce antibodies for the future. And also it also stimulates the T cell. It gets the help of the T cells, which are responsible for formation of the memory cells. So memory cells, they later get stored in the bone marrow, and then they get reactivated at a later stage when the antigen comes into contact again. So this is has got a longer efficacy, safety also, and the number of doses is less. That is usually now what they say is just a single dose, which can be given after 6 months of age. So, and the single dose 0.5 ml intramuscular, and the dosage is the same 25 micrograms, recommended from 6 months onward, routinely, no need of a second dose. Next slide. But for a child who has received polysaccharide, supposing before we give TCV, supposing the child has already received a polysaccharide vaccine, we can still give another dose of TCV, that is conjugate vaccine, at a gap of 4 weeks from the receipt of the polysaccharide vaccine. And routine boosters for TCV is not recommended at 3 years. But initially, according to the 2016 schedule, we were giving one TCV at 10 months of age and another at 2 years. But now the latest after 2018 schedule, it's a single dose after 6 months, anytime. Next slide. And the TCV, now the TCV vaccines which are available now, the conjugate vaccines, several companies have come out with these, but many of them do not have proper approval of or enough studies or limited usage, and they are not very useful. So we have 2 vaccines now. One is Abbott's Entroshield and Bharat Biotech's TIBBAR TCV. And these have the Entroshield, it has human challenge studies. It has got proved efficacy, long-term efficacy, and safety data up to 5 years is available. And the TIBBAR also, there plenty of literature and also evidence for safety also is there. All the others are not very effective for now. So next slide. Next slide. Yeah, this already I told you. Oral vaccines are TY21A oral live vaccine, which is not available in our country. Next slide. So now catch-up vaccination. Those who have not had any typhoid vaccine, they can anytime they get it as a primary vaccination till 18 years, they can be given a single shot. And if not previously vaccinated and they get the disease, they can still be vaccinated after 4 weeks after the recovery from typhoid. They can be given a single shot. Next slide. Thank you. I hope it is a little use to you. And the carry home message here is for typhoid, the latest is TCV vaccine, conjugate vaccines, which are more effective, less doses, and prolonged safety. Thank you. Now, any questions? Any questions? Anyway, I think all of you are tired. Now we'll go on, and thank you very much for the patient listening. And it has been a very nice evening with elaborate talks about the COVID, and it is right from the basics. Sir has touched upon the basics and given us an elaborate talk about everything, and also the critical management also was done. It was very good, and thank you for this patient listening also. And now I ask Dr. Srinivasan, Finance Secretary, to give the vote of thanks.
Good evening to all. Good evening, everyone. And actually thank Dr. Winsley Rose and Dr. EBOR Jacob for the excellent session on COVID. It was very useful to us. And thank you, Dr. Prem Gita, our president, for the vaccination session also. And we thank everyone for joining us in this session. Thank you. Thank you, everyone. And regarding the IMF finance, apart from last time, there has been not much activities, and recent activity which we took up is issuing a sanitizer and mask, and it will be distributed in this weekend mostly. That's it. Yeah. Thank you, everyone.
At this, I also thank our financial sponsors for helping us to make this program a success. And I thank Mr. Prem, who has been with us. And also we didn't get the technical support from our sponsors because some problem. So, but he helped us. He's a maths teacher. He does Zoom classes he does for his students. And he's been very patiently sitting with us. And he's been working with me for the past 1 week and helping me to do this. And thank you very much, Mr. Prem. Thank you for all your patient help to me and to IMA Ranipet. On behalf of Ranipet IMA and the office bearers, I thank you very much. And the sponsors also. And one more thing, I'm very happy to see two of my classmates also, the KMC 77 batch. One Dr. Muralidharan, I don't know whether he's still there here in the line. And I think he's from Australia. And one Dr. Rekha, she was also the IMA president in Poonamali branch in Chennai. For 2 years, she was a president. Hi, Muralidharan. Thank you. Hi. Thank you for attending. Very nice.
Pleasure.
Thank you.
It was a good talk. Really enjoyed.
Hi.
Yeah. It was a very good talk.
Yeah.
Hi, Rekha.
Hi.
Hi,
Nice
Rekha,
session, Alice. Thank you. Very nice.
Oh, thank you. It was a fast sweep through because everybody has patience in the night.
Yeah.
Thank you. Thank you so
Bye.
much.
Bye-bye.
Really enjoyed, Geeta. Thank you. Thanks a lot.
Thank you, Murali. Thank you.
See you again. Bye.
See you. Yeah. Good
Bye.
night. Bye. Good night. Good night.
Good night.
Good night.